Okay, great. So thank you everyone for joining us for this week's AME seminar. Today we have Zhiyong Lu from the NIH. His specialty is in computational methods and software development tools, and he'll be talking today about some of the opportunities and challenges of AI and large language models in medicine. Thank you, Zhiyong. Take it away.
All right. Thank you very much for the kind invitation. So, as introduced, I come to you from the National Library of Medicine, which is one of the ICs of NIH. And we are part of the intramural research program, IRP, where I lead a research group about 15, 20 staff, scientists, postdocs, and other trainees working on using AI and machine learning for both biomedical text and image processing. So I'll fair to say that historically I am a person doing NLP, but since I guess in the last 7, 8 years since the development of deep learning models, we've also started touching on medical image analysis. So that right now counts about 4 or 5 people in my group focusing on the medical image analysis. And obviously, the kind of data that we work with, including both from the text side, we primarily working on tens of millions of articles in PubMed and PubMed Central, as well as patient data when access is given. That includes electronic medical records, as well as patient images. But our focus is typically in radiology and ophthalmology because that's where we have wonderful clinical collaborators. So given the interest and given the background, as I understand from this group, I will try to talk very high level about our NLP research, which I think is somewhat of interest because you go see there's a wide variety of AI applications using NLP in biomedicine. But then most of the topics I reserve for medical image analysis, as well as for multimodal large language model analysis. So those are the ongoing and current research topics in my group. So I will happy to discuss about the research trajectory of my background, but I was telling George that I've been at NIH for the last 17, 18 years, and this is my first and only job I have had after getting my PhD. But I'll talk about stuff starting with the text side, because it's just a very high level overview. And starting with something I think everybody should be very familiar with that is the PubMed database. And perhaps you're also the contributor to this database because we have your papers in this database. So as of now, we have over 36 million articles. And on average day, we have about 2.5 million users. They're doing about 3 million searches and 9 million page views. So this compares nothing compared to Google or other general search engines, but does make PubMed one of the top 3 most visited websites of the United States federal government. So it runs 24/7, even when there's a government shutdown. Occasionally, PubMed never shuts down. So even though AI and machine learning is a very hot topic these days, but since day one, I've been at NIH, which, as I said, about 18 years ago, we've always thinking about using AI and machine learning for improving PubMed search and improving our user search experience. So here's a list of search features that were exclusively implemented using computational approaches, using AI and machine learning. For this talk, I'm not going to the details, but one thing that differs our work from commercial or other general search engine for literature is that we try to be very transparent. For each feature that we listed here, they usually have a paper associated or at least a blog post, that because we believe the more that we can be transparent to our users, the better they will actually trust us and using it to their benefit. So obviously my favorite would be perhaps the last one, best match. This is default search order now in PubMed. Prior to that, the only function people can use for searching for relevant papers is sorting by date, which is still used and occasionally for different user needs, but finding relevant papers is really a no-brainer today in today's research. Now, if you use PubMed, you know this is, after all, a keyword-based search system. So when you have information needed, you need to come up with 3 or 4 keywords. Most of the time, I don't think that's so hard for users to come up with those keywords, but sometimes it's not so obvious. And I'll give you an example where using the previous pandemic, because the term COVID-19 and the SARS-CoV-2 was not actually coined or used consistently in the literature until summer 2020. So every paper that before these 2 terms were used in the literature, they use a wide variety of different names to describe the same thing. And arguably, the very first 3 months or 6 months of the pandemic is the most critical time where we need knowledge about this new disease. So what we did was to create very quickly by a postdoc and engineer in my group come up with a database called LitCovid. The whole purpose of LitCovid is to help users easily find papers about COVID research and only COVID papers. Okay, so as we started, we actually have a prototype in late February and 2020, and in March we're already in full production. And we started with only hundreds of papers and tens of hundreds of papers after in the following weeks. And now we have almost, I think, 400,000 or even more papers in this repository. As I said, that mostly addressed the issue at the beginning for COVID papers. But later on, we have a new problem where, as of now, a lot of papers were using the word COVID just as another term for diseases or pandemic. But the paper itself has nothing to do with COVID research anymore. So now we again have to using AI to filter out those papers, because we want papers only about research, real research, but not just mentioning those keywords anymore. Okay. But after all these like COVID or PubMed, they serve one purpose, helping users to find the papers. Like I mentioned, these days you can find the papers, but most of the time you give it 3 or 4 keywords, you're overwhelmed by the number of papers get returned by those search systems. Oftentimes you get 100 papers, tens of hundreds, thousands, or tens of thousands. So as an individual researcher or biologists, they just don't have the time to go through that long list of papers. So what we really need is an AI that can help us to scan the large set of papers and then generate a summary or generate some kind of connections of those different papers so that we can help us to speed up the hypothesis generation process. So for that, we have made some baby steps. Basically, we need to teach computers to read papers just like scientists, right? And so we need to teach computers, what are the gene names in the article, what are the diseases, what are the drugs names in the article, and what are the relationship between these things. So for that, over the years, that's something called literature mining or information extraction problem. And we have built tools like LitVar and PubTater. They go into the title and abstract, but also the full-length articles when available, and tagging those specific diseases names, drug names, mutations, and their relationships. And as you can see, these tools over the years, we have gone through multiple iterations. Like PubTater, this is the current version is 3.0, LitVar is 2.0. The difference between these two is that LitVar is very specific for genotype-phenotype relationship. And we even not only go to the title and abstract, but also go into the supplementary materials, because variants, mutations are highly enriched in the supplementary materials. But we don't do that for the general system called PubTater, because as you would imagine, people dumping various different things into supplementary materials, PDFs, PowerPoints, spreadsheets, text files, all kinds of Word files. So because of that, it's the accuracy of today's AI NLP tools can vary dramatically when using on the supplementary materials. It's very noisy, so we better not touch them for the moment. But together, these tools has been widely used. We have had over 1 billion access requests, including both web visits and APIs over the years. So far, everything I've talked about is our NLP side, and on the literature side, just one very quick slide about NLP can also be used on the clinical side, on the patient EHR notes. So 2 examples here are, one is that we helped our physicians in radiology to text mine the radiology reports to extract the disease names and then pair them with the chest X-ray data set and made this public available, which you may be more familiar with, called the NIH chest X-ray 14 data set. This really lays the foundation for a lot of deep learning research on medical image analysis to do disease diagnosis and prognosis. And more recently, and that made the NIH News 2017, and more recent last year, we published another article using NLP and large language models to lay a foundation, a new foundation for matching patients to clinical trials using this has been tried in the past using different AI algorithm in the past, but nothing is so accurate or so transparent compared to what we have proposed here. We call it trial GPT. So if you're interested, there are papers published along with these studies. Feel free to read them or ask me if that's of interest. But like I said, because this is a group of medical image analysis, so I will more focus and talk now everything related to image analysis. And I'm going to give the example using our work with ophthalmology, and especially with a disease called age-related macular degeneration, AMD, because this is still a very much ongoing work. This is a disease, if you don't know it, it's a leading cause, one of the leading causes of blindness for elderly population. And it's a progressive disease. There's an early stage, intermediate stage, and late stage. And in the late stage, which I show you here, there's a vision loss in the central vision loss. And unfortunately, there's no cure for this disease at this point. The best thing you can do, according to the clinical trials, is that you can give a high dose zinc, a vitamin, to slow down the progression, but you don't give that zinc to everybody, like us, healthy population. You only give that when somebody has already progressed to the intermediate stage. So for this disease, it's diagnosed by physicians look the back of the patient eye and looking for risk factors such as drusen. These are sort of the fatty deposit on the retina, as well as pigment changes. And there are 2 forms of late AMD or advanced disease stage. One is called a dry form. It's short for GA, geographic atrophy. And then there's the wet form, that's the neovascularization. So as you can see, even though there are physicians to do this, but manually classify the severity of AMD by physicians is a very time-consuming and labor-intensive and error-prone process. Not to mention, in many parts of the world, you don't have access to such physicians. Now, general ophthalmologists that are practicing medicine cannot make the diagnosis for AMD. You need, at least in the United States, you need retinal specialists for this diagnosis. So what we are trying to do then is, can we using deep learning AI to do the disease classification automatically? And we think we can, especially we have some data to train these deep learning models by repurposing the clinical trial data in the past. So there are 2 very large longitudinal trial data called AREDS-1 and AREDS-2, which is actually a household name because, as you can see, some of the eye drops using this are backed by this particular study. So for both trials, they have tens of thousands of images and about 4,000 participants. And like I say, these are longitudinal data. So we have, for the same patient, multiple visits. And what's even more better suited for deep learning is that these images has been manually annotated by people with a PhD level training from those they call the reading centers. So each of these images collected through the trial has been manually annotated by the reading center specialist. So we know if this is a later stage, or this is an intermediate stage, or this is stage 0, which is a healthy patient. So using this data and working directly with our clinical collaborators, Dr. Chu from National Eye Institute, we have done published multiple studies looking at using images only data for AMD severity level classification. We can classify, basically 5 stages from stage 0 to stage 5, which is the late AMD, and 0 is the healthy, and then there's the intermediate and early stage. We also look using these tools to predict the risk, which is more interesting and more clinical relevant because, like I say, there's no cue, and the only thing that is useful is to prescribe high dose zinc. But you don't want to prescribe high dose zinc to anybody. You want to produce to those who are likely to advance to the later stage from the intermediate stage. So work by one of my former postdoc, who's now associate professor now at Cornell, Dr. Pen, who developed this tool called DeepCNet, which basically is a CNN-backed tool. We are able to do these kind of studies that I talked about in the past, and oftentimes we find that these deep learning AI algorithms actually perform better, more favorable compared to the human ophthalmologists. So this is one example where we're trying to ask humans to identify something called RPD, reticular pseudojudging, from the color fundus photographs. And as you can see, this is a very challenging task for human ophthalmologists. Many of the ophthalmologists that we tested are only performed on the diagonal, which is basically random guessing, while a few others are slightly better than random guessing. But AI has been consistently much better in this regard. And because we have tools, AI tools, we can do this. We actually use this tool to assist scientific knowledge discovery. So this is a paper we published, I think, a year or 2 ago, where because of the AI algorithm we have, we use them to annotate a bunch of images that have never been annotated in the past. And using that AI-generated annotations, then we can actually measure the importance of reticular pseudojudging in the context of AMD progression. And later we find there's enough power to show, statistical power to show that reticular pseudojudging is a third risk factor. So we talked about 2, one is judging and the other is pigment change, color changes. And then because of AI, we are able to confirm that RPD, reticular pseudojudging, is a third macular risk factor, so which is quite important. Because of this, a lot of things have to read down for AMD diagnosis. Now, obviously, AMD is just one of the diseases we can use to predict or use to diagnose based on color fundus photographs or retinal images. We can do that for other eye diseases like cataract. We also did that, as well as you can actually using retinal scan to predict diseases that are not related to eyes, which is quite amazing, to be honest, because if you give a physician the eye image, they can also diagnose eye diseases. But if you give physician the eye image and ask them about the person's information about their other diseases, they'll probably say no. They're likely say no. And in this particular study that we collaborated with a bunch of outside collaborators, they found that using retinal scans, you can actually predict a heart attack. In a different study that we pursued ourselves, which is not yet published, we found same kind of effect for cognitive function decline. So these are sort of things that AI is enabling, but something that humans cannot do. Now, how accurate is this? I think this is accurate, pretty accurate. Is it perfect? Certainly not. Okay, I should have said that none of the things that we talked about are perfect using AI, as you probably would agree. But it does not mean these AI things are not useful. It has to, but a lot of time we find that even you ask human physicians to do the same task, they're not perfect either. So a lot of research like this would probably stop at here. Basically, they show, okay, they come up with some kind of new method, and then they apply to a domain task, and they say, okay, now we show that AI algorithm can perform well, can perform sometimes even outperform human experts. But I guess just like my work in the NLP area, we are always interested in developing something and letting people to use that. So the next step that we actually did is that we want to see whether DeepSeaNet, our AI tool for retinal image processing, can be used to assist AMD diagnosis. Okay. And so we sort of went one step further before we think this can be FDA approved, or this can be used in real world scenarios. So we recruited 24 physicians from 12 different institutes, and that includes both retinal specialists as well as general ophthalmologists. And what we like to do is to see, if we give them the same task with or without AI, can they somewhat do better with AI versus without any AI assistant? And we also add a third dimension to compare, is that what if we just using AI by itself? So this is basically the design of the study, which basically, like I say, there are 5 or 6 scales for the severity level classification. So we want AI to determine whether both AI and a human to diagnose a disease based on images for 0 to 5. We also ask them to look at not only pick up the final AMD severity classes, but also 3 independent or intermediate risk factors like drusen pigment and late AMD. And we give the same number of images to these participants or to these physicians with or without AI. But in the end of the 4 rounds, they will see these images, all of them, and then with or without AI. But then we're making sure they're not, remembering anything, because there are things that we do shuffle and regenerate, as well as we take some times off between they do the next round. So on a high level, this is the results that I'm showing you here, is a very high level accuracy. So on the right side is basically the performance of each individual physician with or without AI. So manual means just by themselves, and manual plus AI, as it says, obviously. And as you can see, for all except one, with AI is actually improving their overall diagnosis accuracy. Okay. On the left side is basically a repeat of this information, but not paired with each individual physician. But one thing to note is that AI by itself alone is also performing very well. Okay, so AI by itself, F measure, is already 50%. And while if we look at the right side of AI, manual plus AI, only 5 cases where AI plus human using AI is performing better than just using AI alone. And this is the results when we break down into individual risk factors of AMD, and more or less we see the same results. With AI assistance, physicians generally tend to perform better, but in many cases, the AI alone, its performance is also very strong, except the case of late AMD, which in this case humans seems to be better with compared to AI alone. Certainly with assistance of AI, we see a slight improvement as well. So this basically this results is somewhat mixed, as you can see. So it's hard to say that AI with human is always better than human by itself, first of all. And second of all, it really depends on which human would benefit more from AI versus the others, and in what scenario is going to benefit more using AI versus others. And same thing repeated here. As you can see, if we ask not only the overall classification accuracy, but look at the accuracy of each individual severity level, as you can see, the performance is also mixed. Sometimes AI itself is the best, while others um, you adding the AI plus manual is the best. Okay, so again, this results is we can take one, or we can take just say one suggestion for using AI across the board. We have to look at case by case. But one thing is quite consistent though, is that in terms of efficiency, it seems that using AI is pretty much always is able to uh, result in less time in terms of diagnosis, which is actually somewhat important information to know, because, as I said, this is, a lot of time when we see a healthcare provider, we are given limited time, and if AI can help to provide more time face-to-face interaction, and so this is something that definitely worth considering. So the takeaways for this particular study is that, as I mentioned already, the human plus AI is generally better than just using human, but also not always the case. And some cases, AI alone performs quite well. Now, I guess in the remaining 20 minutes, I would like to talk about, and this was done actually prior, everything is done, what I presented is pretty much prior to November 2022, when the ChatGPT was first launched. And I have to say, and if this is probably also your impression, is that at least for an NLP text generation, text understanding capability, there's nothing uh, more stronger compared to what's out here. Okay, and that makes it no surprise to me that it grabs 1 million users in within 5 days, compared to much longer time for other popular online services and applications. There are some early wins you've probably seen in the news, such as a boy saw 17 doctors over 3 years for his chronic pain with no diagnosis, but eventually his mom typed his symptom and ChatGPT were able to generate the correct diagnosis. Obviously, this is cherry picking, and that's why it made the news. Certainly, it's not always the case, but it does, on some benchmarking, when ChatGPT was launched, it does show that ChatGPT is able to achieve very well on the USMLE exam test. This is the medical tests examination question and answers provided to the medical students in the United States, and the passing score is 60. Okay, and GPT 3.5 was already achieving over 60, a score of over 60, and within a very short period of 6 months, the models were reaching the high 80s. That's close to human attending level performance. Now I'm pretty sure it's now probably already in the 90s, if not perfect. I have to say, for those of us that work in NLP, this is not a trivial task. Okay, people have lots of attempts in the past before ChatGPT, and at the time, the best performance is in the 30s and 40s, and 1 or 2 point percentage increase at the time would, prior to 2022, would be considered a very significant, and that definitely worth a top tier CS conference papers. But I guess nobody, at least for me, I did not foresee that there's AI that can actually work so well on such a task. So, but for this task, it's basically you take the questions in a multiple choice, and then take the question in text description, and then you take the multiple questions. So along the line, we did some research in a multimodal fashion. Okay, and this because for this group, you're very interested in an image side. So we actually worked with our radiologists and we worked on multiple two separate studies in 2 consecutive years, working on something called a case of the day at the radiology conference, the Radiology Society in RSNA in North America. So this is something that actually very interesting because at the RSNA, which is the premier conference for radiology annual meeting every, I think, November in Chicago, there's a very popular education activity at RSNA, that is the case of the day. These features very challenging clinical diagnosis cases from a wider range of different subspecialties within radiology. And this is designed, these tests are designed to test the clinical knowledge and diagnostic reasoning on very sort of more difficult than the average cases. These are displayed on the screen, as you can see here. And throughout the day, each day they will release some new tests, and then participants can review the cases during the day and then submit the answers via online answer portal. So here is example that one of the tests on Wednesday of that meeting, I think in 2023, each case is accompanied with a vignette text description about the patient, about patient history, and then also accompanied with the radiologic images. And then there's a question, and the answers are in the multiple choices fashion, MCQ, multiple choices. So there are 4 choices here, and the new cases are released every day, and then the solutions are shared during the conference the next day, okay? And so over, I think, 3 or 4 days period of the conference, there are new cases released each day, as I mentioned, and they're different in different topics. As you can see, there are a wider range of different topics. These case studies will be released and provided to the participants. So in 2023, after attending the RSNA conference, someone from my group designed, and together with our radiologist collaborators, designed a study where that was also the time. Remember, I think October 2023 is the time when the multimodal GPT-4V version first launched. So they quickly looked at this as an opportunity to test to see whether GPT-4V at the time is able to answer these case of day data or tests correctly, because these are the tests released after October 2023. These were released during the conference in November. And in comparison, as a reference, they also have access to radiologists and radiologist residents. They want to look at the human performance as a baseline, and then to look at if we provide the GPT-4V version answer to the humans, could the human physicians answer them more accurately? Okay, so those are the 3 different study objectives for this particular study. And in total, there are 76 cases in that year, and 4 were removed because these cases includes videos, but GPT-4V can only handle images, but not videos. And then there are 30, so therefore there are 72 remained, and 10 questions, you can answer them without looking at images. So we call them image independent. And then the remaining 62 are the image dependent cases, where in order to answer the question correctly, the information in the image is very critical. And there are 3 residents recruited and 5 radiologists. So this is the bottom line results of that particular study. On the left side is the results on the 10 questions, which does not rely on information from the images. And then on the right side is the 62 majority of the cases where image does is an integral part of the tests. So as you can see, in generally speaking, GPT-4V worked not that great compared to human physicians, radiologists, or residents. Radiologists does perform better compared to the residents. Okay, and that all the results are shown on the B side, on the right side I'm talking about. And then when you adding the GPT-4V results to the human physicians, they do not help them. And the reason they do not help them is because the GPT-4V result itself is pretty poor. Okay. And on the other hand, when we look at those 10 cases where we don't need image to answer the question, the performance of the AI is actually much more accurate compared to those needing for the image analysis. But again, in this case, radiologist at the attending level has the best performance, while in the resident's case, resident is not as good as the AI. And therefore, when you add in the AI suggestions or AI answer to the human physicians, radiologist alone does not get any benefit. But given that information to to the medical residents, they are actually able to answer the questions better. Okay, so the take-home message is, in this case, whether or not AI is able to assist or help depends on how good the AI performance in relation to the human performance. And because of that, we did that study. We started to do that. We thought this would be interesting to look at after attending the 2024 meeting, which is in November 2024, because at that time now we have much more, many more AI models. Because in October 2023 or after November 2023, GPT-4V was pretty much the only model that we can use. Well, this year, after 2024 November, we have many more models that we can test. So our focus has been whether or not we can actually to trace the progression, the progress that this AI has made over 1 year period. Okay, just over 1 year. Remember, in 2023, when GPT-4V was first launched, there are in no comparison for those 62 cases that requires image comprehension, their performance is way below human performance. But guess what? After 1 year, we find this has changed quite significantly. So again, we rerun the newest models on the 2023 as a reference to their results on the 2024. We see that couple of things we can see from this table. Okay, one thing is that 2024, we have more cases compared to 2023, and these cases tend to be even more difficult than 2023, previous year. And that is consistent when you compare the results in the by the AI as well as the results by two radiologists, because we used the same two radiologists. They did the 2023 and they also did 2024. As you can see, 2024 performance are generally a little bit lower. That's one thing to see from this table. The other thing you can see is that in 2023, the GPT-4V is way lower than the radiologists. But in 2024, the best GPT-01 model is actually quite consistent, quite comparable to the human performance. Okay, so this is quite amazing. I would say, just like what we saw in the medical exam within a 6 months of time, the GPT from 3.5 to GPT-4 quickly reached human performance on the medical USMLE medical exam tests. Same thing happened we see here for the case of the day in the radiology RSNA. Within a year, the GPT-01 model, the multimodal model, actually performed just as good as radiologists. So if we were to do this in 2025, I would probably predict the GPT AI is going to be even better. Okay, so For the remaining 5 minutes, I will just quickly go through some limitations while we're doing this type of a benchmark, because all we do here is that we look at a question, and we're trying to ask AI to pick an answer in a multiple choices fashion, okay? But in real world, as we all know, if a physician look at a patient, there's no choices. There's no list of finite answers they would pick from, right? There's and number two, so that's the first thing, is does not exactly resemble what's in the real world, real life. Second of all, is even AI gets the answer correctly, even by random guessing, they have 25% of chance. But if they are getting, but they certainly are smarter than the random guessing. Do they really understand this? Do they really give the right reasoning to understand this and can explain why they are picking this answer? Is their reasoning actually sound and correct? So for that, we actually did a study and published a study last year, and we find there's some hidden flaws in this part. And this is sort of the finding that I'm showing here, but the actual study starts like this. We're trying to answer two questions now, and this is broadened from just looking at radiology space. We look at a wide variety of different specialties, and we are motivated by two questions. One is, how does GPT-4V compare to physicians in multiple choices accuracy? Number two is, can GPT-4V explain its decision-making process, especially from three different aspects? Can they understand what's in the image? Can they recall the right information to answer the question? And given the medical knowledge and given what's in the image, do they give the right reasoning to select the final answer? And for this study, we used the web version of the GPT-4V, as I said, released in October 2023. And then we picked over 200 questions from the New England Journal of Medicine. These are online sort of cases, just like the case of the day, very similar, but these are posted online. And we made sure these questions were posted after October 23, so that these questions has not been used as a part of the model training data. Okay, because otherwise, nobody knows what data they use for model training. So this answer could be already leaked in the model training. And just like the case of the day, we recruited physicians, including 1 MD student and 9 physicians. As you can see, differently from the radiology study, we have included a wider variety of different disease specialties, dermatology, neurology, cardiology, pathology, so on and so forth, ophthalmology. And then we also have images in different image modality, including the CT, including the X-ray, including the MRI, so on and so forth, pathology. And we use human physicians to do two things. First thing is, just like the radiology case, we asked humans to answer those questions and then compute their accuracy as a reference to compare with the AI performance. Secondly, we asked this and when we do that, we ask physicians, because we invited physicians from different specialties, and some of the physicians are ophthalmologists, okay, and they would only answer the questions in ophthalmology. We're not giving them into dermatology questions, okay? And then second thing we ask humans to do is that we ask them to manually assess the quality of GPT-generated reasoning process, and from those three aspects, because we ask GPT to generate what's in the image, what's your medical knowledge you're using, and what's your reasoning process. So we asked humans to assess whether they are correct or incorrect. So the first round of results is not that surprising. As you can see, students are only getting about 60% accuracy, while human physicians in a closed book, which means that they have no access to their colleagues, consult, or no access to Google search, they're doing about 78% accuracy, and GPT-4V by itself is 80%, but there's no significant difference between the two. But when we allow physicians to have access to their colleagues, to Google searches, they can quickly increase their performance in the 90s. So in other words, physicians are still doing better than just GPT-4V, which is something that actually quite consistent as we presented in the radiology case of today's studies. But the most interesting thing that we find, we call it hidden flaws, is that in 1/3 of the time, when AI makes the correct choice, okay, they pick the correct answer from A, B, C, D, 4 different options, there's still issues in their decision-making process. And majority of the cases, or the most cases, happens in their understanding of the medical image. Okay, that accounts for the most of the issues, and followed by using the right knowledge or the right reasoning step. Okay, so this is something that is, to us, a little bit surprising, but also very interesting, because we need to understand that we cannot blindly trust their answer, because their reasoning process, their decisions making process can still be very much flawed. And this just showed you one such example where even for me, who's not a medically trained researcher, I can tell that there's difference between the two eyes in the image. But as you can see in the GPT-4V output, it says there's no specific abnormalities showing in this MRI image, okay, which is clearly incorrect. So just before I close, just to show you that, we do a lot of LLM research, and that's probably the reason why I was invited to speak here. But as a single research group, I don't think we are in a position to compete with the private sector to produce the best and the most powerful LLMs. But rather, what we are interested approach is that we, first of all, benchmarking these standard large language model on tasks that are important in our field. And when we do that, we often find there are ways, this is sort of our CS background comes through. We always find ways that we can enhance the standard large language model with some domain knowledge, either through retrieval or augmented generation, or using some other methods. But I have to say that as much as I'm amazed by the power and capability of today's large language models, we have also found some issues in their current technology. So that as we move along for these new technologies in production or in real life, we have to acknowledge and mitigate these issues. And that's why we also have an arm. In fact, I mentioned I have a student, PhD student from computer science, whose thesis is to sort of, first of all, to discover those limitations, and second of all, to address these limitations using different techniques. So with that, I will think we're right on time for some quick discussion. But before I do that, I just want to thank, even though I'm speaking on behalf of a wonderful team, as well as our colleagues, both within and outside of NIH. So thank you very much.
Great. Thank you so much for a very interesting talk. Let's give a virtual round of applause to Zhiyong.